Good afternoon and welcome to our Orthopedic and Sports Medicine lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Optus Health International. It is my pleasure to welcome all of you to this very informative and interesting presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located on the bottom of your screen. I will be your moderator today, so I will be watching out for those questions. This afternoon, I have the pleasure of introducing Dr. Cary Chapman, who is a board-certified orthopedic surgeon at Baptist Health's Miami Orthopedic and Sports Medicine Institute. His presentation is titled 3D Printing Technology Applications in Foot and Ankle Surgery. Dr. Chapman specializes in minimally invasive surgical treatments for the chronic and acute foot and ankle injuries, ankle arthritis, ankle replacement, bunions, and hammer-toe deformities. Dr. Chapman received his medical training at the Columbia University College of Physicians and Surgeons in New York. He completed his orthopedic residency at New York Presbyterian Medical Center in New York City and a foot and ankle fellowship with Roger A. Mann, MD, in Oakland, California. Dr. Chapman joins Miami Orthopedic Sports Medicine Institute from NYU, Long Orthopedic Hospital. His extensive experience includes more than a decade of private and academic medicine in New York City. While a faculty in NYU, Dr. Chapman was the first surgeon in New York State to successfully perform a custom total ankle replacement using innovative 3D printing technology. He also previously served as a chief of foot and ankle surgery at the University of Miami. Aside from his clinical and direct academic experience, Dr. Chapman continues to do research and has been published in numerous peer-reviewed publications, including the Journal of Foot and Ankle Surgery, Cartilage Orthopedic Foot and Ankle International, and the American Journal of Orthopedic and the Journal of American Academy of Orthopedic Surgeons. He has had the honors and privilege to present his work at leading regional and national meetings, as well as lectures, and shared his experience in many orthopedic topics at continuing medical education conferences. He's a diplomat of the American Board of Orthopedic Surgery, a fellow of the American Academy of Orthopedic Surgeons, and an active member of the American Orthopedic Foot and Ankle Surgeons. Some of Dr. Chapman's awards and accolades include being recipient of the Castle County, New York metro area's Top Doctor Award and the New York Super Doctors Award 7 years in a row. We have no doubt that he is a super doctor. Please, let's give a warm welcome to Dr. Cary Chapman. Dr. Chapman, thank you so much for joining us today in conference.
Dr. Hakim, thank you very much. I don't know if, hopefully I'll live up to that, introduction of yours. So I'm just gonna move on to our talk right now. So as Dr. Hakim said, I'm an orthopedic surgeon and I subspecialize in foot and ankle surgery. I take it you guys can see this.
It should be coming.
So the talk is on 3D printing technology in foot and ankle surgery. So this is something that's been coming on for the past few years. But just in review, I'm part of the, and proudly part of the Miami Orthopedics and Sports Medicine Institute. We are a 20 plus board certified orthopedic providers, subspecialty based. And we pretty much cover all of these subspecialties in orthopedics. So within the division of foot and ankle surgery, there's myself, Dr. Hodgkins, and Dr. Sam.
I apologize, but the presentation hasn't projected. Maybe we should share the screen again. My sincere apologies.
All right, I'm sorry about that.
No problem. We got it. We can see it.
Oh, okay. Well, I got to start this. All right, you see that?
Oh, it's perfect. Thank you.
All right, I'm so sorry about that. So, so before starting, I just to give a little about the Miami Orthopedics and Sports Medicine Institute. We're a subspecialty based group that covers essentially all of the subspecialties in Orthopedics, and I recently joined in January, and I'm so proud to be part of really an elite group of orthopedic surgeons. So within the foot and ankle division, there's myself and Dr. Hodgkins and Dr. Sangiovanni. We're all board certified and fellowship trained orthopedic surgeons. We have our own orthopedic foot and ankle fellowship, and between all of us, we pretty much cover everything in foot and ankle surgery. We're really into ankle replacements, minimally invasive surgery, the more difficult reconstructions, like you'll see in the next few minutes, and sports related cases. So, for people who are experienced orthopedic surgery, when you look at these images on the top here, you've got a difficult problem. So you see, failed total ankle here, talar AVN here and here, and these huge bony voids. These problems lead to really, at best case, poor solutions, such as on the left here, this is an extensive hindfoot fusion, which leaves the foot extremely stiff. And sometimes it can lead to amputations. So what is 3D printing technology, and how can it possibly help? So essentially 3D printing technology is fusing materials together to make a solid object. That's also known as additive manufacturing. So you can do that with plastics, metals, ceramics, and hopefully one day with living cells. So on this image over here, the top, we have something called additive manufacturing, where we will lay down layers of material, and eventually with those layers, you create this object here on the right. So subtractive manufacturing is essentially the opposite. Say you have a block of marble over here, you have a milling device, and the milling device removes the excess marble, and then you end up with a similar object. So with additive manufacturing, you can make very complicated, intricate objects, such as this piece of work on the right here. You can make, they're currently making sneakers out of using additive manufacturing, or 3D printed additive manufacturing, and recently they made a house out of 3D printing technology. So essentially, how does it work? And in particular, for what we're going to talk about today, you'll have something called computer-aided design, where you'll get let's say a CT scan of something, and that CT scan will be converted into some type of computer program, and then the computer program will go into the printer, and then you get a printed object of what you initially started with. So this is the best way I can explain it. I'm not coming off as I'm definitely not an expert in 3D, how 3D printing technology works, but I think this is a simple way to think about it. So what are the advantages? You're able to customize goods. You're able to produce complex products. You can eliminate steps in assembly and reduce the need for inventory. And of course, the disadvantages are going to be cost. But just like most technological advances, these costs come down over time with greater use and improvement in technology. So what are the current medical uses for 3D printing technology? Right now, the simplest one is just to make an anatomic model. So you can make a model of a child's skull, which you're going to do a complex cranial surgery on, and practice that surgery first. And some hospitals, such as Randy's Children's Hospital in San Diego, have 3D printed labs where they'll make a model, in this particular case on the right, of a patient with scoliosis, and the surgeons can determine the best way to fix that. Other uses include custom medication. So think of it as, if you have, let's say you take a atenolol for hypertension, and the dosages are 10 milligrams, 20 milligrams, 30 milligrams, etc. What if you only need 12.5 milligrams? That's something that can be 3D printed. Also, they could hopefully one day they'll be able to make a layered medication. So instead of taking 5 pills in the morning, you only have to take 1 or 2, and those pills contain separate medications in them. And these are, this one medication here was the first 3D printed drug in the United States in terms of getting FDA approval. Here's one that's more for the future, and I think this will be the focus of 3D printing moving forward, is something called bioprinting. So they're using a computer and a printer here to essentially lay down layers of living cells through a pipette instead of metal and plastic. So this is obviously an artist's rendition, and I think this is something that is probably, this may happen in our lifetimes. So this is the reason why we're here today, is what are the orthopedic applications for 3D printing? Basically falls into two sets here. The first one is a custom instrumentation or guides, and the second one are custom implants. So for custom instrumentation, it's quite easy. Let's say that in this particular example, this device over here is a custom guide for a total ankle replacement, and we'll get a CT scan of the patient's tibia. And here is the printed out CT scan, and they'll make the guide that corresponds to that. Same thing with the tibia. And we use this and place it on the patient, and it probably saves about 15 or 20 minutes of fiddle factor in terms of us making our cuts for an ankle replacement. So here's the actual fun part, and that's custom implants or patient-specific implants. And they can range from what I would consider an easy case, like this one. There's a 50-year-old female with avascular necrosis of the talus. You can see here that the talus has collapsed. And the CT scan shows that essentially most of the talus is dead. So previously, our options would include doing a very extensive fusion procedure, which has a high chance of not healing. And you're also trying to get dead bone to heal to live bone. And you're leaving the patient with a very stiff ankle. So with 3D technology, what we can do is, in the gray here, this is the patient's other talus. It's their good talus. And in the blue is the patient's affected talus. So the good talus is flipped. The data from the CT scan is flipped, so it becomes the same side as the affected, the AVN talus, and they're able to make an implant out of this computerized rendering. And this is what we end up getting. We end up getting 3 tali. One is the size that we had initially measured through the CT, and there's one that's a little bit larger and one that's a little bit smaller. And this is what it looks like after placing it in the ankle. So this is something where a patient can maintain their motion. They can still have a good pain relief and not be left with, which is essentially a debilitating salvage procedure, that being fusing the entire hindfoot. And this was recently approved by the FDA this year. Let me just move on. So here's a harder case, or I would consider a harder case. You have a patient here with ankle arthritis, but if you look closely, there's a lot of cysts in the ankle and in the talus. And here's our CT scan. Once again, you can see that the talus looks like Swiss cheese almost. And there's a huge cyst in the calcaneus. Here's our sagittal view, looking from the side. Once again, the talus is full of holes. And here you see the arthritis in the joint above. And there's a large cyst in the calcaneus. So really, what are our options with this patient? Well, we can do an ankle replacement. The issue with the ankle replacement is that the patient has a lot of cysts or holes in the talus, and that may not provide enough structural support, even with bone grafting. When I say structural support, I mean support for the implant itself. So that would increase the chance of an early failure. Another option would be something called a tibial-talo-calcaneal fusion, which is basically fusing the tibia bone to the talus and the talus to the calcaneus. That is a debilitating surgery. You're not left with really any motion in the foot, and the patient had good range of motion and preferred to maintain that. So what we thought of doing is essentially a total ankle replacement, but we're going to replace the talus as well with a 3D printed version based on his unaffected side. And once again, this is the blue is the patient's affected talus, and the gray behind it is the other talus, which is normal. And here is, since we're doing an ankle replacement, we have to make the talus, the top part of the talus, correspond with the brand of ankle replacement or the type of ankle replacement which I was going to use for this case, and that was the star. And these are just other pictures they send. They'll send me, and I wanted to use screws, and they showed what direction the screws would go in. Here's the talus itself. This is the top of the talus. This is the talar head. This is the bottom. I wanted this part of the talus to fuse to the calcaneus. And here we've performed our tibial cut. We've removed the entirety of the talus. That is a mold of the one I decided to use. This is a picture with a tibial spacer in and our talus spacer in. And here's our intra-op fluoros. And this is a 2-year follow-up. The patient's doing well. He's returned to work part-time. He's enjoying his semi-retirement. And then we move on to what I consider our really hard cases. And this is a combination of using a custom-made guide and a custom implant. So this patient right here is a middle-aged female who I did an ankle replacement on about 7 years ago. She had, over the past 6 to 8 months, increasing pain in her ankle. And when looking at this, you could tell that this portion of the ankle replacement has started to sink a bit. In addition to that, there's arthritis of the subtalar joint. And in my first surgery, I did what's called a talonavicular fusion. So I fused the bone that was the navicular to the talus here. Here's a CT scan showing in these black spaces, there are cysts underneath the talar component. There's also cysts around the barrels of the tibial component. You can see them better here. Once again, you can see these cysts. So basically, if we took this talar component off, this is all empty space right there. There's really no bone supporting it. Up here, we're not totally sure if there's any bone. There's enough support in the bone. So, you know, this is what I would consider a higher level case. The plan was to do a custom total talus and total ankle replacement. But we had to be prepared to revise both parts. We're definitely going to take this out and put a new talus in. And we were going to see at the time of surgery if this tibial component, which I'm pointing to, and hopefully you guys can see, is secure enough so that it doesn't need to be revised. So because of that, we needed to have 2 separate total talus components made, one that matched the star, which is this brand of prosthesis, and there's another one called the InBone, which is better for patients who have, you know, bony voids. So the other thing we need to do is fuse the subtalar joint. So the talus we wanted to grow into this bone over here, and we had to take down this fusion, the talonavicular fusion, and to fuse this new talonavicular joint. So with 3D printing technology, we were able to make a cutting guide, which would precisely allow us to cut at the correct spot on the around the talonavicular joint. And we needed 2 different types of taluses. So hopefully you can see this. The talus here on the left has a little bump here, that's for the star. And this one on the right has more of a recessed ridge, and that's for the InBone prosthesis. So we actually had 2 or 3 models of each one of these of similar sizes. And you can see here, there's just a lot of trays that you need to have ready. So we determined that the tibial component was stable, so we did not have to revise that. So I ended up choosing the talus that had the notch for the star. Here's our cutting guide. We have to cut through the bone here. I packed both areas where we wanted the implant to fuse to the bone with a bone graft substitute. And here's our intraoperative fluoros. So we're trying to get this talus to fuse to the calcaneus bone and what's left of the navicular. And here's the patient at 1 year after surgery. And once again, not running marathons, but doing things that make life worth living. Even activities of daily living can be a challenge for some folks. So in terms of, well, is there actually any literature out there on this type of these type of surgeries? Well, most of them are case reports. There are so many obscure types of surgeries to do with this because there's different options. But since we're just talking about the talus, in the last year or two, a couple articles have come out. Parekh and Duke showed significant improvement in pain and function with patients who received total talus replacements at 2 years follow-up. There's a group out of Japan that had 22 patients with the combined total talus and total ankle replacement after 3 years, and they also showed improvements in range of motion and function. Of course, there's complications which can occur in any surgery. And just so I'll just show a couple other cases that are not talus related, because I don't want you to think that this is all we can do with it. These cases actually belong to colleagues of mine. This patient's a 60-year-old male who had his metatarsal head resected for what's called a problem called metatarsalgia. But because of that, he started to develop a bunion over here, and then he started to develop pain underneath this metatarsal head because this one is gone. So that's a condition called transfer metatarsalgia. So the conventional option would be fusing this joint here, making it stiff, and then removing these other metatarsal heads. So that's really not a great option for an active person. That's something that we would do in the past on patients with rheumatoid arthritis, and really didn't move around that much. So in this particular case, we're able to make essentially a metallic metatarsal with this intramedullary component over here. And then there is a plate attached to the metallic metatarsal, in which screws were placed through the implant there. And I believe this X-ray is something like 3 years follow-up. Here's another case where a patient ended up getting an infection of the navicular bone right over here after surgery, and it required multiple surgeries. This one down here is after we placed some antibiotic cement, and the options at the time, once again, were limited. Prior to 3D implant technology, this guy is essentially looking at either an amputation or taking a large amount of bone graft, and when I say bone graft, probably his own bone graft, which has issues with structural integrity and donor site morbidity. So with this technology, you can build your own implant over here. This is the final product, but you're using CT guided imaging to create this. So here's the implant that was built. This is the implant packed with bone graft. Intraoperatively, there's the void after cleaning everything out for the last time. And here's the implant itself in the foot. And this is a follow-up image showing that this void has been filled and the bone has grown into the implant. So in conclusion, 3D printed patient-specific implants can allow for treatment of really difficult orthopedic problems that had previously very limited options. There's truly a limitless possibility of what can be made, and really it's your imagination that is the guide to that. So whatever you can think of can be made. And this also allows for, let's say, advantages over allograft or donated bone. Allograft has its own issues with bone resorption, collapse of the allograft. So these structures are sound. They have the type of detail within the structure that allows for bony ingrowth into the structure itself. So there's really less concern for collapse. And that's it. Thank you very much.
Thank you so very much, Dr. Chapman. How exciting and what an incredible presentation. I am sure that we will get some questions soon, but it is remarkable what 10 years of technology has actually brought to medicine, how we have changed and how we have evolved to use technology more and more. And one thing that we take from your lecture is the fact that eventually this very costly, perhaps costly procedure might eventually be accessible to everyone simply because the technology will improve as well as obviously the feasibility due to the fact that we're using more and more of it. It happened exactly with the Da Vinci robot. It happened exactly with laparoscopy at the time. So, and now we see this very exciting new method of actually helping these patients. We have a couple of questions. We have almost 400 participants today. And I want to encourage all our docs, if you cannot do it in English, it's okay to write it in Spanish. I'll do my best to translate for Dr. Chapman. But Nicole has a question, and she says, "Good afternoon. My name is Nicole Hatchman. I am a biomedical engineering graduate from RIT. Could you please tell me the materials you use for using the to be able to 3D print these devices and how you sterilize them before they go into the patient?"
Okay, so the initial, from what I've seen, the current metal is titanium alloy. In terms of sterilizing them, once they're made, they are sterilized just like any other instrument is sterilized. It's not a special sterilized, like they don't come out of the printer sterilized. They come out of the printer as they are, and then they're brought to the hospital where the hospital will put it through its regular sterilization process. Did I miss the part of that question?
Yeah, and did you mention it was titanium?
Yes.
The material, great. Cesar Fermin is from the Dominican Republic, and he's wondering, insurance companies cover traditional osteosynthesis materials implanted in various surgeries, but are 3D printed parts covered by insurance?
Well, from what I've seen, yes. I'm not an expert in reimbursement for procedures. I know that there are certain codes that we, at least in the United States, will use a code like a talectomy, or there's a code for a total ankle. So you can include this in those codes, and typically what happens is the hospital will get paid a certain amount of money for the code. And in addition to that, provided their contracts with the specific insurance carriers, they will get paid for the implant itself. Usually this is something that the hospital keeps, they keep it to themselves as to what they get paid. But I do know that sometimes when the hospital is in a very strong negotiating position, they make money on the implants. And I tell you right now, the implants are very expensive. But what is the cost of losing one's leg?
Right.
We could put a dollar amount on that, but I'd rather not.
I agree with you, and maybe I could shed some light as well. The fact of the matter is, yes, that all implantables are extremely, extremely costly. However, we go with a very stringent way of selecting those devices or implantables that physicians can use or should use in a hospital. But sometimes we do take a hit, Cesar. Sometimes the physician says, the best way to actually help this patient is by doing, let's say, a 3D printing type of technology and procedure. Therefore, we will code it as if it was one of those approved type implants already, or the ones that we have already agreed to utilize and use. So we do take a hit at times. Just to refresh everybody's mind, it happened exactly the same way with the robotic surgeries. We used to charge them at the time as if they were laparoscopic surgeries. So more to come on that, but the insurance companies will continue to be challenged with the advent of new technology. Debbie Marty is from Mexico, and she is wondering, how many 3D printers does Mosme have? What do they look like size-wise? Who does the actual programming on this printer? Gracias.
I don't think we have any, we don't have the actual 3D printers. I mean, there's some large hospital systems that may have it. I think in New York, there was one hospital system that had it. It's essentially, there are a couple companies that make this, and I don't know, am I allowed, Dr.
Yes, of course.
So there's the one company I use is called Additive Orthopedics. You can look on their website on how these things are made. I don't, once again, I'm not an expert on the actual production of these implants, but they get the CT information. They take the digital information out of the disc, which I give them. I know they have an engineer. The engineer is in South America, and it's a really cool process. You come up with a plan. The engineer will give you whatever it is that you want as best as he can, and then you go over with the engineer the plan. You go over all of the pictures of the plan. You want to put a screw in a different direction. You just show them how to do it, and somehow the engineer makes it happen. So I wish I could answer that a little better for you, but that's something maybe you go on the Additive Orthopedics website. There's a lot of cool stuff on there, and yeah, like
so it all starts with the actual imaging.
Yeah, I order the CT scan. That's my role in the beginning of this.
Correct. All the slides are sent to the company, and the engineers are the ones that purge this through the printer. And then it's shipped back to Dr. Chapman so he could use it in his surgery.
So in the cases that we want to, let's say for a talus AVN case, where the talus that we want to fix is a dead, it's not the talus we want to use. Let's say it's the right ankle. We get a CT of both ankles, and they'll take the digital information from the left ankle, which is the normal ankle, and literally invert it. And now you have a right ankle, which is a undamaged ankle, and they'll use that digital information to make the implants that I showed in the beginning, those talus implants.
Fantastic. Which programs or platforms do you use for the 3D CT reconstruction? I think we already answered that. It is based on the imaging department's compilation of these particular slides are sent to the engineer, and they purge this for us to use. So thank you for the question. Ana Catalina is from Costa Rica, and she says, wow, very impressive. How long does the planning phase takes before the surgery and recovery after these type of surgeries? How long should we say that the patient needs to remain in Miami?
Okay, so the actual turnaround time depends on the complexity of the project. So I can tell you most of them can get done within 4 to 6 weeks in terms of building the implant. In terms of how long do I need to stay in town, that is that's patient to patient. There's a lot of different variables involved, but in general, I would say that you'd have to stay in town for at least 2 to 4 weeks initially. I will typically see a patient that, let's say my total ankle patients, I want to see them at 2 weeks and at 6 weeks. So as long as the skin is healed and we think everything's fine, you can go back home, but we still need a continued follow-up over the course of many months. But in terms of like the acute phase, it's going to be at least 2 weeks and most likely closer to 4 weeks.
Excellent. And probably rehab right after. Do we need to actually include rehab in those 4 weeks, or that's
I'm sorry, in the beginning, for most of these foot cases, if you just look at your own foot or ankle, I mean, look at it, it's skin and bone. I don't want anyone messing with it until the skin heals. So in the very beginning, there's really no rehab. The rehab is keep your foot elevated and take it easy.
And that's it. So Rudy is from Peru, and he's wondering, what are the possibilities or risks of the patient's tissue, rejecting the 3D printed prosthesis?
Well, we don't reject these things in a traditional sense like we would reject an organ. These things are inert substances. So they should not cause a reaction. When we use it in conjunction with, let's say, the ankle replacement, that in the replacement essentially is metal and plastic. So when you're moving your ankle, you can create little pieces of microscopic pieces of plastic or that get worn away over time, and your body can have a reaction to that. Now that's been seen in hip replacement and knee replacement, but we haven't seen it in ankle replacements. And certainly if it's just metal and no plastic, unless you have some obscure, rare allergy to the metal, there shouldn't be any issue. It's like any other inert object that we put in people. We put plates in people all the time. We do all these surgeries that they don't, the body doesn't react to it.
Rudy also wonders, can the 3D prosthesis be used in children, given that the prosthesis will not grow with the bone?
I don't think it's FDA approved for use in children. It would have to be an off-label use. I mean, I certainly wouldn't. I mean, it's a complicated question. It doesn't have a simple answer. I mean, I think that you could do it if it's not around a growth plate or a joint. But in general, we don't have any. These things typically aren't done in kids.
From Colombia, very interesting presentation, doctor, about the talus case. How the subtalar joint fusion works? Is there any chance that the calcaneus ends up being compressed or fractured by the talus due to the axial weight bearing of such?
All right, so that's a great question. Let me see if I can get that picture of the talus back. All right, so the implant itself has it has these pores that allow for bone to grow in it. So if you're familiar with how we do fusions, essentially we will remove what's left of the joint and we'll chop up the bone and we'll create some bleeding. And then essentially these edges of bone where there used to be a joint here, we chop them up and then they just kind of fuse together because bone can do that. Let me see if I can share my screen. So can you guys see this, the talus here?
Not yet.
Not yet. Why do I? All right, I keep on missing it.
There, it's coming.
Okay. So this is the top part of the talus. This is the part that articulates with the tibia. And this is the undersurface. This is the part that we want to fuse to the calcaneus. So let me see if I can make this bigger. You can see almost like a honeycomb appearance of this, these little tiny holes in there. And you see these little tiny spikes. So within this little tiny spike up here, the surface of that spike has little indentations in it. So bone from the calcaneus, provided everything goes well, will actually heal, will grow into these little channels over here. Let me stop sharing. Okay. So how do we stop it from breaking the talus or breaking the calcaneus? Well, for a situation like this, I'm going to treat it like a fusion. So when I do a fusion on a patient, I have them off of their foot or non-weight bearing on whatever limb I'm operating on for at least 6 to 8 weeks. And I do the same thing for this. So that during that 6 to 8 weeks, the hope is that this, the patient's native bone will grow into those little channels that you saw on the bottom of that talus. And they've actually done a couple post-operative CT scan studies where they show, I don't know the exact science behind it, but there's ways to show bone growing into these little channels.
Wow. We have a question from Dr. Christian Omar de la Cruz from Madrid. He's in emergency medicine in Spain. My question is, Is it possible to create the 3D implants for patients who have had bone loss or catastrophic limb due to a traffic accident or serious trauma?
Yeah, I didn't even get into that. I don't, it's the answer is a definitive yes for people who have lost, let's say, a segment of their tibia. Um, they have, they've created essentially, I don't want to say artificial tibia, but they've created large areas of metal that will replace the amount of tibia that was lost. So I didn't get into that because I just want to stick with foot and ankle surgery, but this is definitely has great applications in trauma surgery, and it has applications in orthopedic tumor surgery. So this is definitely it's definitely been done. It's looks a little wacky, but it's once again another tool that a skilled surgeon can have to help his or her patients.
Absolutely. One more question, and this time is from Honduras. Androla is wondering, how long would a titanium ankle replacement will last, and how effective is it?
Okay, so I'll answer that question in two parts. The first part is if you just talk about ankle replacements on their own, what we have out today, I can tell a patient with good confidence and be able to go to sleep at night that you've got probably an 80 to 85% chance of having a regular ankle replacement still in you in 12 years. That's not bad. It's not that much worse than a knee replacement. A knee replacement is probably 85% chance in 15 years. So what we don't know is, how long, we don't have long-term follow-up on these total, the total talus implant. We have probably 3 to 5 year follow-up out there. I personally probably have like 3-year follow-up. I haven't revised anything yet. If you could have this option where you're 60 years old and you can keep your ankle motion until you're 70, and then maybe if you're 70 you get a fusion. I think that's definitely something worth considering. I mean, I for one would not want a fusion at my age or even 10 years over my age if I could avoid it.
Absolutely. And one of the things that we look forward to, it's actually helping those patients that have failed arthroplasties in the past, that at times physicians will say, listen, I'm at a loss. The surgery went bad. You have lost your bones. We cannot do much to help you. And now this is like a light at the end of the tunnel for many. Dr. Chapman, this is all very exciting. It is wonderful technology. We are ecstatic that you are and you have decided to join MOSME and our group. I think that the prospect of the use of 3D, not only in orthopedic, but other centers of excellence is going to be absolutely phenomenal. But I commend every single one of you guys in MOSME. You do phenomenal work. And with that, I honestly will keep you here for hours on end. But just to be considerate to you, we know you have patients waiting. And on behalf of our entire team at Baptist International, I would like to thank you for your presentation and to all of you for participating today. If you have additional questions about the presentation, feel free to email them to us at BHIWebinars@baptisthealth.net. We promise to get them to Dr. Chapman for his response and send them back to you. We look forward to seeing you in our next Orthopedic and Sports Medicine lecture series, which is scheduled for Wednesday, September 1st, 2021. In the meanwhile, please stay safe, and we shall see you soon. Thank you so much, Dr. Chapman.